I'm really honored to be here with you all today, and really honored to be a small part of the COE program. I was privileged to be part of the launch of the Centers of Excellence when I worked with the State Department of Human Services. Back in 2016, there were a lot of challenges and a lot of kinks to work out with this COE program. And there was a lot of opposition to this program as well, a lot of detractors who tried to derail this effort, a lot of closed-mindedness around the COE program. There were people and organizations who said we didn't need this program. They couldn't understand how the COEs might work because it was foreign and frightening to them for many reasons. They said the grant funding that you all received would be better spent elsewhere, yet here we are, here you are all today, 4 years later. Lots of data to support the effectiveness of what you all have done. Spreadsheets of data that I know in the early days and probably still today are nightmares for you all to complete because the state had asked for a lot of data. You've expanded access to MAT. Data shows its effectiveness in keeping patients engaged in treatment. Your outcomes through this program are such that Pennsylvania has said expand this program to every provider that qualifies. I think that is very significant and a direct result of the great work that you all have done. But I believe the most important thing that you've done in the 4 years is likely saved hundreds, if not thousands, of lives during the worst ever overdose death epidemic that we as a state or a nation have seen. And I'm certainly very proud to have been part of this mission-driven work with you. The mission for me, and I know it is for you, is to save lives and to help people recover from this disease and to give them a better life than what they have, whatever better looks like for them. Likewise, we as COEs and providers, I think, have an opportunity to get even better. So I'm here today to talk about the stigma that exists today within our own system against medications to treat the disease. As I mentioned earlier, Dr. Fauble really did an excellent job in looking at how important language is to what we do. I certainly don't have all the answers. I am going to share with you some of my experiences, my perspective, my suggestions and recommendations based on the last several years, both working for the Commonwealth and now for a provider. So without having all the answers, I'm going to ask for your help in figuring out a way to solve this problem together. How do we better provide medications to treat the disease of addiction, opioid use disorder in particular, so that we can work through our biases, whether those be implicit or overt? And I believe a lot of these biases are driven from the way we provide this type of treatment. So how as 45 COEs do we collaboratively work through this problem? You know, in 2016, if those closed-minded people who weren't willing to try something different to save the lives of our patients had gotten their way, we wouldn't even be having this conversation today. So as we do have it, I would simply ask you to have an open mind and let's see what we can do together. So let me pose a question. If I can advance the slide. Here we go. Are people who use methadone or buprenorphine as prescribed in recovery? My answer to this question used to be no. And unfortunately for many who work in addiction treatment today, the answer is no. Many times those who believe that quote unquote true recovery can only be achieved when there is no use of any medication don't even recognize their bias against it. It's an implicit bias. And I'll share an example with you. I heard this quote spoken a few months ago, in fact, by someone at a center of excellence. He said, certified recovery specialists are always wondering what more can they do to help the patient's recovery efforts in conjunction with the case managers and the doctors. They're also advocating all the time for the patients to begin the titration off of Suboxone for continued recovery. That's a very telling sentence right there. And I think that's really good because the patients are hearing it from the doctor that they should do that at some point. They're hearing it from the case manager. They're hearing it from the outpatient provider. And they're hearing it from the CRSs, and they're hearing it from their sponsors in the community. Now, what that sounds like to me is every component of the addiction treatment system is badgering the patient to stop using a life-saving medication because in their opinions, continued or long-term recovery is impossible with medication. That's what I see and that's what I hear when I see that statement. And again, I used to believe that myself because my own recovery story is one that doesn't include medication. That was my lived experience, and so that was my opinion. It took months of me meeting with mothers and fathers, sons and daughters, husbands and wives, thinking about the deaths of my only siblings, my two brothers, and how that's affected my parents. It took all of those very sad stories that were shared with me about the death of loved ones. Oftentimes after multiple trips through a revolving treatment door, for me to realize that we were doing such a disservice to our patients by not encouraging greater access and use of medications. I think needless to say today, I am a staunch supporter of medications to treat the disease of addiction. So against that backdrop, let's talk briefly about treatment and recovery. I think most of us can agree that the goal of addiction treatment is to stop drug abuse and return people to productive functioning in the family, workplace, and community. This is a definition provided by NIDA, the National Institute on Drug Abuse. I think there's much less consensus on the definition of recovery. Here's one definition. This comes from the Pennsylvania Certification Board, the very organization that certifies the CRSs who are on the call today and part of the COE program. The Pennsylvania Certification Board says recovery is highly individualized, requires abstinence from all mood and mind altering substances, and may be supported by using medication that is appropriately prescribed and taken. I think this isn't a bad definition, but there are some issues with it. It stands to create confusion or conflict in some people's minds. And, you know, Robert, we have a polling question where we were going to ask folks about whether they've ever had an experience where a person's 12-step philosophy did not align with MAT. And if we can do that poll now, that would be interesting to see what we get from the folks. But the problem I see in this definition is that it creates confusion because for those who come out of the 12-step world, and I understand there's many paths to recovery, but there are a lot of people in our field today, many of our certified recovery specialists who come from a 12-step philosophy. And hey, by the way, I am a staunch supporter of 12-step. I am an active member in a 12-step fellowship, so I am a supporter. But the problem is this idea of abstinence from all mood and mind altering drugs. This is language that comes directly from 12-step fellowship. And in the 12-step fellowship, medications like buprenorphine and methadone alter the mind. And so you cannot have one with the other. You cannot have abstinence from mood and mind altering substances while using a medication to treat the addiction. That is the problem with this definition and the conflict, I think, that it can create. So if we look at another definition, this one from SAMHSA, the Substance Abuse and Mental Health Services Administration. Recovery is a process of change through which individuals improve their health and wellness. They live a self-directed life and they strive to reach their full potential. Now, this is a much broader definition, at least in my read, versus what we looked at previously, and it casts a much wider net, and it's more inclusive. Although the previous definition uses the words highly individualized, this definition really embodies individualized recovery. And I would encourage you all to read more about SAMHSA's definition. You'll find in it, there's also a reference to abstinence from alcohol, illicit drugs, and non-prescribed drugs for those seeking recovery from addiction. You'll also find that there are 4 major dimensions that support a life in recovery according to SAMHSA, and that's health, home, purpose, and community. My point here isn't to say that recovery shouldn't include abstinence. I'm not saying that at all. Nor really is my point here to say that one definition is necessarily worse than or better than the other, but really to point out that there are multiple definitions of recovery, many more than these two. I'm not sure. Robert, can you? I'm not sure what's happening, but all right. So my point here was that there are multiple definitions of recovery, many more than these 2 that we've looked at. Some would simply say that recovery equals abstinence plus change. To help us understand, I think, what it is we're trying to achieve for our patients and what we're working toward, we would be well served to be working from the same page and toward a definition of recovery that clearly allows for use of medication rather than perpetuating any bias, whether it's inadvertent or not. And I think this would be a good exercise for any COE, really any provider for that matter. What is it that we collectively believe is recovery, and what is it that we're working toward on behalf of our patients? I want to be respectful of my time, and anytime you give me a podium or a microphone, I can tend to go long. So I want to talk just a minute about what the research says about medication to treat opioid use disorder. I'm not going to get too far into any data here. I know that you all have seen it probably in a variety of different ways. The bottom line is the research for decades has shown that medication keeps patients engaged in treatment longer, and we know the longer they're engaged in treatment, the greater the likelihood they'll remain in recovery. I won't read these bullet points for you. You can certainly read them, but we know that patients who use methadone, but certainly buprenorphine as well, have much greater outcomes, and those who remain on medication continue to improve and maintain these gains. I'll share one specific piece of data with you. CCBH does a very good job of compiling data from, I believe it's 18 centers of excellence who are part of its network across Pennsylvania. The most recent data that I had seen shows that 67% of COE patients who use methadone as part of their treatment are still engaged in treatment at the 6-month mark. That is far greater than those who use buprenorphine, and especially much greater than those who use no medication. The point being here that the data is indisputable. Medication is a great tool to keep people engaged in treatment. So I was asked to come here today to provide some real world examples of how we can work to reduce stigma and bias, especially from our COE perspective. First thing I want to talk to you about is my experience with my organization's residential treatment centers. In Pennsylvania, we have 13 opioid treatment programs, 13 facilities that provide each of the 3 FDA-approved medications. Majority of our patients use methadone as part of their treatment plan. But in the other states in which we have operations, we also have residential facilities. And today we're providing medication throughout the residential stay, not just in withdrawal management, but throughout the entire residential stay. And this was and continues to be a change for us. It was very new when we implemented it, especially when you look at how we historically provided treatment. And so we are in the process of piloting a program that will, in some ways, create MAT ambassadors. It will create MAT ambassadors, not in some ways. What we're looking to do is find and empower MAT champions, because despite the data that I just showed with you, depending upon your personal experience and your own experiences with those to whom you provide care, you will have biases. I found in my conversations with the residential facilities, oftentimes these biases are perpetuated through misinformation or missing information. And so what we want to do is, how can we better help educate our peers? How can we put in place a linkage between the front line of treatment and senior leadership in order to elevate concerns and questions and conversely bring back solutions? In other words, if as providers and as clinicians and frontline staff, we see things happening that we're not sure should be happening, or that we have questions about, maybe in fact they shouldn't be happening. We need that ambassador to be the linkage, but we also need the ambassador to help educate his or her peers and also really carry the message that MAT works. The jury's still out on how effective this will be, but I think it's something for you all to consider within your COEs and your broader provider organizations as you think about ways to influence and change opinion relative to MAT. We also talk a lot about building an MAT supportive environment. Some of these suggestions would seem very obvious. Thoroughly vet your prospective employees. In one of our COEs very recently, we had interviewed a prospective employee who did nothing but bash medications as part of her interview, yet she should have known fully well she was interviewing with an opioid treatment program. And so in that interview process, you have opportunity to ask questions, find out what the experience is of that prospective employee. It's also an opportunity to begin to dispel myths and to educate these folks. Talk about creating a culture of open-mindedness. I think this is very important. I've talked about open-mindedness several times today. One of the biggest problems I see in my travels and in my experience is that what works for one does not necessarily work for others. What worked for me in my recovery may well not work for someone else. We hear it, though, said time and time again by folks in our field and in recovery that if I could do it, anybody could do it, but that's not necessarily true. In fact, I had opportunity this week to sit with 3 of our patients at Miners, Miners Medical, one of our COEs, and had great conversation with these 3 patients, each of whom uses methadone as part of their treatment plan, each of whom is having success in their plan and in their recovery. And there were some common themes that they shared with me, one of them being that methadone was the only thing that helped them remove the obsession to use heroin. That by engaging in use of medication, they were now able to, through their counselor's help, focus on addressing those problems and issues in their lives that otherwise they never would have been able to focus on, because their whole being is about the obsession and the compulsive use of drugs. And so My experience does not include medication, but certainly we need to expand our bubbles to know that in an open-minded approach, what worked for me does not necessarily work for others. We need to have the mindset that treatment is not punitive, that patients should not be shamed. We need to meet patients where they're willing to accept treatment. And I'll give you an example here. Oftentimes we see patients who are using a medication as part of their treatment plan, and in our perspective, they're failing. They're not doing the things that we expect them to do. They're not compliant with their treatment plan. Well, in fact, we may well be failing that patient rather than the patient failing treatment. And there's some simple things that our clinicians have shared with me that we can do. Look, the patient-counselor relationship isn't always a great one. And so simply by moving that patient to another counselor, we've often seen great success. A change in counselors has brought about a great change in that patient. So we need to be considering things from the patient perspective as we look to address and improve, as I said earlier, the provision of medications. And one last thing about managing expectations. Our patients, many of them, have been out there using for a long time. We're looking at recovery as a process. We look for progress, not perfection. And really, we need to be celebrating every positive to get to the big picture. The last thing I would say very briefly about reducing stigma and bias, back to my earlier point about the residential facilities I've had a chance to work with. When you get in there and talk with folks, even though you assume that because everybody's in our field, they understand deeply medications, that's not always the case. We need to be going beyond simple definitions of methadone, buprenorphine, and naltrexone to help our folks better understand the pharmacology. Who is a good candidate for MAT and why? What do the phases of MAT look like? Induction, stabilization, maintenance, and ultimately titration. I think through better education, and I saw some people put this answer in their chat, we can do a much better job. Let me wrap up by talking about what's at stake. What happens when we allow our personal bias to influence our interactions with our patients relative to MAT? Of course, we create barriers to the form of treatment proven most effective at treating their OUD. We ourselves are advocates of our patients, yet we perpetuate stigma when we allow personal bias to influence those interactions. We shame and guilt our patients, and ultimately we risk our patients' lives based on our personal philosophies. And that's a very easy gamble for someone to make when it's not his or her life on the line. I think if we look at things in this perspective, we can do a much better job. I often say, as part of the presentations I give, I mentioned earlier, both of my brothers, Todd at 28 and Josh at 25, both died from drug overdose deaths. I'm the last living son of my parents, in recovery myself. I can tell you today that my parents would much rather have their two sons alive and on a medication to help them in their treatment than laying dead side by side in a graveyard in Portage, Pennsylvania, Cambria County, Pennsylvania, which is where they are today. Many of you value open-mindedness in your personal lives. I certainly do. We need to practice that same value in our day-to-day work. So my ask of you as I wrap this up is that you approach the very hard, life-saving work that you are all doing every day with an open mind so that we can help our patients find the best path for them to a life of individualized recovery.